disease reservoir. We talked about the various modes of disease transmission. We listed the use of epidemiology. And then now we may begin today with the basic epidemiological methods, and maybe we mention the functions of an epidemiologist. So that is what formed the basis of our discussion earlier. So today we are going to talk about the epidemiologic study designs. So to begin with, there are many, we have an objective. We have an objective which we have to do, and that is to describe observational and analytical study designs and their use in epidemiology, and also recognizing the most appropriate circumstance under each design. So the outline which I'm going to use to present these observation and analytical designs, I'm going to explain the types of epidemiological studies, and then to discuss the most appropriate circumstance. So this most appropriate circumstance is just to put or to try and put these studies into context, just to make it easier. So hold on, I'm just trying to bring those slides up. Thank you. Good. So, so to start us off, or to begin with, epidemiological study designs can be divided into two broad categories. And these categories, we are talking about descriptive studies and analytical studies. So the two major types of studies, when we are talking now, or when we are singling out the descriptive studies, we have two major types, which we refer to them as the case report or case series. And then we also have ecological study designs. So I will take you through this to try and understand when we talk about epidemiological study or descriptive studies. So those ones which I've already mentioned, we classify them as descriptive study designs. So we have also other types of analytical study designs, which we are going also to discuss. And in analytical study designs, basically we are talking about cross-section studies. We're talking about case control. We're talking about cohort and randomized control trials. Remember, in our definitions of epidemiology, we talked about determinants and we talked about distribution. Where we say that when we're talking about distribution, basically we are talking about the descriptive studies. And then when we're talking about distribution, we are talking about analytical studies, which are the cross. So here now we are still deducting from that definition. So there is some debate on how to categorize these cross-sectional studies, but I will list it as a descriptive study because some may list it as descriptive study, but I choose to term it as analytical study for the reasons which we shall cover as we discuss each and every of those designs. So basically, the reason as to why we classify it as descriptive, it is because I believe that we are doing more than just simply describing when we are doing the cross-section study. Yeah, most of you use this cross-section study in your research. So basically here, we are only not describing, but often in this study, we are able to give more than just describing. So people will often ask what's the best study design, like some of your colleagues have asked me in their research that which is the best study designs or in epidemiology. So basically I would like to respond and say there is no inherent best study design, but the best study design is the design that is most appropriate to your scientific hypothesis or your question. So it depends what you want to find out. There is no study that you can say it is better than the other. So, but what determines the study that you may, or what you want to find out, either if you want to be analytic or you want to be descriptive, then your hypothesis or your scientific question, which basically in your research you are told are the objectives. Yeah. So these are the things that will determine the type of study design that you will choose. So the study designs in a nutshell that we have in epidemiology particularly, we have descriptive and we have analytic. So descriptive, now we have gone further and said that we have number one, case report. Number two, we can have case series. And number three, we have ecologic study designs. And then in analytic, on the other hand, we are talking about number one, cross-sectional. Number two, case control. Number three, cohort. Number four, randomized trial. So those are the ones which are existing. And in randomized is where now you will find some will do the experimental and quasi experimental. Yeah. So all those may occur, particularly when you're talking about randomized trial, because here we shall discuss where there is element of the control group and the case, where you have now to follow up. Maybe you are trying a new drug, so you give one class a drug and another one you give a placebo. So one is the ones which are actually getting the drug are the case, and the placebo are the ones who are now used as the control. So it can be used in experimental and the quasi-experimental. So we shall discuss that even as I give you some study designs that I have done to see how it is applied. So we have descriptive studies, which we are discussing. We start with descriptive studies, so we shall talk about the case report, the case series, and ecological. So these ones are under the descriptive studies. So, so let us start with the descriptive studies. And again, this, as I have mentioned earlier, these are the case reports, the case series, and the ecological studies. So as we go through each of these study design, I will start with an example, and then we'll walk through the details of each design, right? So, so our first example is actually of a very famous case series, and this was published way back in 1980s. You can be able to see published by this journal, in 1980s. In the journal was the New England Journal of Medicine. So it is quite a good journal. So, and it was reported, there were reports of individual with pneumocystis carinii, pneumonia in the US men. And this was unusual because this pneumocystis carinii or the PCP pneumonia was actually at that time in the 1980s, it was very rare. Yeah. So, but there were reports. So And all of a sudden, because it was rare, all of a sudden we find there are 5 individuals in 5 months. All these individuals were homosexuals, and then all were previously healthy, and they had unexpected immunodeficiency. So that is a case published in a journal, that there were reports of pneumocystis carinii, which was rare in the 1980s. And then all of a sudden, in maybe in a hospital, there were 5 individuals within 5 months. All were homosexuals. All had previously, were previously healthy, and then they had unexpected immunodeficiency. So that one is an example of a case report, yeah, whereby it has all the hallmarks of a case report and a case series, because these are typically reports of individual, unusual case presentation. So a case report is that of an individual, while a case series is usually a number of individuals with unusual case presentation. So basically, the purpose of case report or case series, it is usually to share unusual cases. We normally ask you to go to the clinical area and write case studies. Those ones fall under this category, the case report. You find an interesting case, unusual, of an individual, and you come and report. So because the essence is to share unusual clinical cases, right? So sometimes these case reports and case series, they are just odd occurrences, but sometimes they usually signal something new or unexpected. So basically, it is just telling us the tip of an iceberg. So when you go back to this case series or this presentation, where there were 5 individuals, all homosexual, and cases of pneumocystis carinii in 1980s, is where now we find later we had HIV. So it was unusual then, but it was just giving us the tip of an iceberg. There were a lot of things beneath that the people then did not know. For them, they just saw the unusual cases of pneumocarinii. Yeah. So this means that clearly you find that the case report and the case series of all the 5 men and the PCP pneumonia or the pneumocystis carinii it is important in epidemiology, because we can be able to use them to bring forth the unusual clinical cases, and then from there now we can be able to get what is beneath. So that one is descriptive. You just find cases. When it is an individual, it becomes a case report. So this one is an individual. And then when there are series of individual, there are many, then it becomes a case series. Yeah, there are many people with unusual clinical characteristics. Very well. So that said, we go to the second one, which is the ecological studies. So when you look at this, it is also another case. So this again is a hallmark example of an ecological study. So this one was one of the first studies that actually provided early evidence that circumcision may be protective against HIV. You can be able to look at that map of Africa. So in this study, the author simply took all of the information that he had about the prevalence of male circumcision in Africa, and then he was able to plot it, to map. When you look at this, it is areas where there are male circumcision. So he mapped them, yeah, in different geographical area. Then he overlaid the HIV seroprevalence. So he was able to map and see where HIV is more prevalent. So you can be able to see as per the key we have this dot, it is less than 1, here it is 1 to 4. When it is highly condensed, you find it is more than 10. So when you see at like this point, there is no circumcision. Look at this area. The seropositivity, look at this area again here. Yeah. Look at the areas where there is no circumcision, where I am highlighting. You can be able to see there is a lot of case load, because when it is shaded, it is non-circumcising region. And then when we have areas which are blank, are areas where circumcision is applied. When you look at this North Africa, the Arabic country where circumcision is even done early, you see there is less HIV prevalence. And then look at this part of East Africa and Central Africa where there is no circumcision. You can be able to see the caseloads of HIV is high. Look at the Central Africa, you see? So, so as you look at the map, you can see that most of the high seroprevalence areas corresponds quite well with areas where male circumcision is not practiced. So, the unit of observation in an ecological study, we are talking about a group of people rather than individual. And these groups, we are talking about countries, cities, districts. So where you take a group of people and you try to give an average, like you have been able to see that person was able to map out the whole of Africa where circumcision is taking place and where there is none circumcision. And then from there, he was able to depict the HIV seroreactive. So you find out that an ecological study is one where the unit of observation basically is the group of people rather than individual, as we have said. So as you are measuring things on a group level, and these groups can include a number of different types of groups, and we're talking about countries, cities, districts, it could be classrooms, and so on. So the key thing about ecological study is that you are measuring your exposure and outcome averaged over individuals in the group. The exposure here is circumcision, and the outcome is HIV. So basically, you are measuring the exposure and outcome average. You have been able to see that we are using groups. So it is the average of the individual in that group. Basically, you are not going out and testing each individual person, but rather you are just saying in this area, maybe it is Kenya, maybe it is Egypt, the average prevalence of male circumcision is X, and the average prevalence of HIV infection is Y. I hope you are following. Is there a question up to there? Any question or clarification? Good. So silence means that you are following. So we shall carry on. So ecological studies basically have what we call ecological fallacy, whereby we are ascribing a member of a group characteristics that they do not possess as individual. Because let's say we are talking about circumcision in Kenya. Most tribes will circumcise. So when we are mapping out circumcision in Kenya and HIV prevalence, we assume that every person in Kenya is circumcised. Yet, it is not true. Yeah? So that is what we are talking about, ecological fallacy. So basically, when you hear the ecological fallacy, You are ascribing to members of a group characteristics that they do not possess as individual. Like when you say Kenyans circumcised, you are as if saying everyone does that, but in real sense, it is a particular group of individuals who do, whereas there's also another group that does not do it. So in a nutshell, descriptive designs tell us what the disease looks like. The study usually only includes people with the disease. There is no comparison group. And the first step in identifying an occurrence is where we do descriptive designs. Yeah. I want you to take time and try to digest that. When we're talking descriptive, we have said we have case, series, case, report, and ecological study. In the case series, we have said is where we have many people or we are finding something unique and common that is not happening. And then now we are reporting, like the case of the pneumocystis carinii. And then we're talking about the case report, we are talking about individual. You find an individual with a unique, rare condition, so you report on it. And then ecological, we are talking about the average. We are measuring the exposure and outcome as an average, yeah? We're talking about the average of a group, but not an individual. So when you look at the case report, case series, ecological, which are descriptive study designs, basically it only tells us about disease, but there is no comparison group. We cannot compare this and that. So it just describes, it is actually where we say it is the first step in identifying a new occurrence. The next study designs are called analytic study designs. So on the other hand, analytical study designs are often considered more powerful because they tell us about the measure of disease frequency. And the disease frequency is how often does a disease occur in a population. Remember, in a descriptive, we don't get the frequency. It just tells us there is an occurrence, but it does not go further and tell us how often. And then again, it measures or it measures disease association. And disease association basically is what characteristics are more common among people who have disease or infection compared to those who do not. So those are the analytical study designs. They tell us how often a disease will occur, that is the frequency, so it makes it more powerful. And then it also tells us about the disease association. How common is it among the people who have the disease as compared to those who do not have? So I will give you also another case so that we understand when you are talking about analytical study designs. So there was a study conducted in Pakistan among the urban men where there was a discussion on the STI prevalence and associated factors. You see, it is giving us the disease, it is giving us the frequency, and it giving us the association. You see, frequency is prevalence, or how often. And then this one is association. And then STI is the disease or the exposure. And this will be, so the objective of those study was to measure the prevalence of selected STI and identify the risk factors. The study population was 2,400 urban men enrolled in 6 cities in Pakistan. And then the method that they used was structured behavioral questionnaire, where samples of blood and urine for STI, HIV, herpes simplex virus, T. pallidum, which causes syphilis, Clostridia trachomatis, and Neisseria gonorrhea were obtained. So the result found that 4.4% of men who were positive for one or at least one of the STIs. Let me check my yeah. So it was also found that an older age, less schooling, and 4 or more sex partners was associated with STI. So basically, when you look at that, that one is a descriptive because it is giving us association. Older age, less schooling, 4 or more sex partners associated with what? STI. You get? And then it's also giving us the frequency that 4.4% of men were positive. So it is just not describing about the STIs and leaving there. It is also going further and telling us what is associated with the occurrence of the disease. So the first one, remember in analytical study designs, we said we are going to look at types, where we said here we have the case, cross-section studies. We said we have the randomization or randomized studies. We said we have the cohort studies. And then we also said that we have, which other one? We also say that we have the case control. Case control. So the cross-sectional studies here we are talking about, there's an exposure and there's an outcome, all being measured at the same time. So this is a classic example of a cross-sectional studies, the way that you are seeing here, and it had the hallmarks of cross-sectional study in that you are looking at time and you are measuring the exposure and outcome at the same time, like in this study, whereby the exposure is this and then the outcome is STI, and you are looking for association. So basically in a case cross-sectional studies, the exposure and the outcome are measured at the same time. So in cross-sectional studies, the measure of disease, frequency, and association are done at the same time. So in terms of measure of the disease frequency and association, then you can be able also to calculate a few things, or can be able to calculate from the cross-sectional studies to be able to measure the disease frequency and prevalence. So, and also it's often the reason why we conduct cross-section study is so that we want to find out what the prevalence of a given disease is. So this is measured as the number of the disease over the total population at risk, where your total population at risk basically, or is typically all the people who are enrolled in the study. Like in the case of Pakistan, there were all those men that were there. Yeah, so those were, that is the is your total population. So when you want to do the prevalence of a disease, is the N. N is the total population of a disease or case over the total number of people at risk. For example, when you're talking about 200 STI cases over, let's say the population in Pakistan is 10,000. And then we can give this as a percentage, or we can give it as a decimal. So times 100. You will be able to get what? The prevalence. So also in cross-sectional study, you can be able to calculate what is known as the odds ratio, where the odds ratio is the incidence with the exposure over the incidence without exposure. So here it's supposed to be like this. Is the incidence with the exposure over the incidence without exposure. And then we can also be able to calculate the risk ratio, which is, there is a formula which we usually do, where we have the incidence of disease in exposed over the incidence of disease in unexposed. So this is the table, which I will not want to discuss much about it at this point, because we have not gone deep to be able to do we are not going deep to be able to do these calculations. But when you are plotting or you want to calculate the risk ratio or the odds ratio, there is a table that you usually form, where this is the person's exposure. You compare exposure and the disease. So these are the people with disease minus the people without disease. And then the positive here is the people who have been exposed, and this one are the people who are not exposed. So you can be able to calculate a lot using that table. So that is not our objective as of today. But whenever you meet, or you can be able to go and read about these other two, the odds ratio and the risk ratio. But basically, I would like you to know about the prevalence, where is the number of disease over the total population at risk. You can express it as by 100% as a percentage, or a decimal, or a fraction. So what are the advantages and disadvantages of cross-sectional studies? As you have seen, one of the advantages that you can be able to calculate the prevalence. We are going to talk about this in our subsequent slides. And then it is efficient and not too expensive. And often it is done early in our understanding of the problem. So a disadvantage of cross-sectional study is that we cannot draw any conclusion about causality, what is causing. Because we are measuring, remember we are measuring in a cross-section, remember in this diagram, we are measuring the exposure and the outcome at the same time. So we don't know, we cannot be able to tell what is causing the outcome. And then it is prone to selection bias. Any question? Any question from the class? Or any clarification that you may want?
Okay, a question.
Yes, James.
Under that prevalence, you have said the formula is the new cases of the total number of the population. My question is it applied by 100% or
yes,
not?
you do it by 100% for you to be able to report it as a percentage. But you can also be able to report it as a decimal point. So either way, it is still acceptable. So like remember for that case of, let me show you of how the reporting was done. I'm having some trouble here, just 1 minute. So let's say, look, for example, in this case, you can be able to see, we are talking about 2,400 urban men in 6 cities in Pakistan. So that was the population. So this is the population at risk. So after collecting the sample, it was found that 4.4% of the male were positive. So when you look at this, it is given as what? Percentage. So basically, if you want to calculate the number of those ones who are positive, you will say if 100% is equals to what? 2,400. So what about 4.4? Yeah, so it is 4.4 times 2,400 over 100. So this, and then when you do this, approximately you find it to be basically, let me try and calculate it. That is, let's say 4 point. Didn't carry my calculator today. So it is 4.4. It is 4.4 multiplied.
I think it's 105.
Yes, approximately 105. Thank you very much. So now, let me now show you what I wanted you to get. Let me discard. So in this case, you will find that 2 or 4 urban men were enrolled in the city. So this one is the population at risk. So those who are found with positive cases of STI are 1 or 5. Yeah. So now, when we want to go and calculate the prevalence according to this formula, we will take the N, which is the number of disease, which is 1 or 5, over the total population, which is 2,400, and then we multiply by 100. So from here is where we get 4.4%. Or this one can also be 0.44 or 0.0. Yeah, you can be able to see in ratio. So you can be able to calculate it in fraction, or you can be able to calculate it as percentage. But if you calculate it as percentage, it makes sense because a person can be able to work reverse like we have been able to do for us to be able to get all these figures without mentioning. That is why you find you express it mostly as a percent. But even if you do it as a decimal, still we can work backwards. I hope, Marwa, now you can be able to get your answer.
Thank you. I've gotten.
You're welcome. So you have been able to see that in cross-sectional studies, we can be able, this one we have been able to talk about it, where we have said you can be able to calculate prevalence, you can be able to, it's not expensive because it does not, you do not take time following people over a long period of time. And then again, you cannot be able to draw conclusion as a disadvantage because the exposure and outcome, you are measuring it at the same time. Okay, so we carry on. The next one is also another case, which we are also going to use it to learn and make it easier for us when we are understanding these things. So here now, we have a case, which is a classical example of a case control study, whereby we have a case that was published in Biomaker Preview 2018 of sexually transmitted infection and prostate cancer risk. So the objective of this study was to determine if STI are associated with breast cancer. Remember, there is an association here, which we said it is an hallmark characteristics of an analytical study. When you see something like association, you know automatically it ceases becoming descriptive. So we had cases where men with prostate cancer, N was 868, and those men had blood sample collected from them a year before they were diagnosed. So they also enrolled a group of men without prostate cancer, which were around 1,283, who also had a blood sample taken, and they matched them on the year that the blood sample was drawn. So the method here that was applied, they tested the samples from both the cases and the controls for the serum antibodies to a number of STIs. The result was that among whites, there was no association between STI and prostate cancer, while among the blacks, the risk of prostate cancer was approximately 2 times higher among men who had chlamydia trachomatis. Yeah. So from this, in a nutshell, we had 2 groups, the case and control. One case had prostate cancer, and the other group did not have prostate cancer. And blood samples were taken from these groups, and then it was tested for STIs. So it was found that among the whites, there was no association between STI and prostate cancer, because there is a lot of mathematics that we usually do to be able to find this association. And then among the blacks, there was association of the risk of prostate cancer with those ones who had chlamydia trachomatis. So this is a classical example of a case control study, where in a case control study, you actually start at the end. Yeah. When someone already has a disease. So like here, we started at the end. Already the people had what? Prostate cancer. So we are starting from the end. And then you select a sample of case or individuals with disease. And then you also select a similar sample of people without disease. And then you look backwards in time to see what they were exposed, and you compare the exposure in the case and controls. So basically, or affirmatively, when you look at the case control, we have cases and we have control. The cases are those ones who already have the disease. And in our example, the disease was what? Prostate cancer. And then you also select a group of people without the disease. No disease. So these are people without prostate cancer. So you start here and then you look backwards. Yeah, you look backwards and try to see what were the people in the case exposed and not exposed. You look at what they were exposed and not exposed. So when you look at that, then you can be able to make conclusions or make inferences that those people with prostate cancer, they may have exposed themselves to STIs, particularly Trichomonas or the chlamydia trachomatis. So you have case and control. So in a nutshell, very rarely do you calculate the measure of disease frequency from a case control, because already the disease has occurred. So you are not interested with how often. So we are most interested in the measure of, we are here basically in the case control, we are measuring disease association. For example, when you look at your environment, you can be able to see throat cancer. So you see males with throat cancer, you see women with throat cancer. So you go back and you start now asking them questions, or you find out their lifestyle that they lived before. And you realize maybe they were taking hot tea, maybe they were taking alcohol. And then you also find another group which does not have throat cancer. And then you also look behind. Have they been exposed to this similar causative agent, or things that you suspect would have caused the disease? So basically, we are trying to associate that we are trying to look for a link between these cancers and a previous exposure. So, and again, this is where we calculate our odds ratio, remembering that this represents approximately the risk of acquiring or having a disease. So the odds ratio I showed you, but I don't want you to trouble yourself much at this level with odds ratio. So what are the advantages and disadvantages of case control? The advantage, it is good for rare outcomes. We can assess multiple exposure. It is efficient and cost effective, because the disease is already there. So you are just trying to associate what could have caused. The same way when your patients come, they say they have headache. So you ask them, have you had any stress? Do you have diabetes? So you are trying just to look backwards to look for the association or the cause. That is an example of a case control. The only difference is that when these persons come to clinic, you don't compare it with another person. But in a case control, you need the case group and the control group. You start with the disease and look at the exposure. So you are going backwards to find a link. So that makes it very cost effective. It makes it, you can be able to assess multiple exposures. Maybe you say this person, like in this case, in this case, STI, prostate cancer, you can even associate them with lifestyle. You can associate it with hygiene, so you can be able to associate multiple exposures. So disadvantage is that you cannot calculate the prevalence of the disease, and it is difficult to determine what we call the temporal sequence. You cannot be able to actually affirm that the exposure that you have highlighted, maybe we have said those ones with STIs are linked or are associated with prostate. We may not give scientific proof, but we are actually speculating. So we cannot determine temporal sequence. And then again, there is potential of bias, where you can be able to decide maybe to choose some people and avoid some people. So it has a potential of bias. So in also the temporal sequence, I want to mention that sometimes you cannot be sure that the exposure that you are looking for happened before the outcome. That prostate cancer appeared or happened to be there with your patient before they had STI. It could be that they had prostate cancer and then STI came later. So it is difficult for you to be able to say with certainty that the exposure came before the outcome. It could also be reverse. Okay. So where we have the case control, you have already said that study design is referred to as what? Case control study. So we have another one called cohort study. So let us learn from this research and see what a cohort study is. So here we are talking about, there was a study published by Lavris in 1999, where he talked about the effect of circumcision on incidences of HIV type 1 and other STDs, or the ST, sexual transmitted diseases. So the objective of this topic was to determine the association, yeah, between male circumcision and HIV acquisition. The study took place in Kenya, where the study population was Kenyan truck drivers who were 746 and seronegative at enrollment. And then unexposed, meaning they were not circumcised, and it was around, out of those truck drivers, around 13% were not circumcised. So the outcome that we were looking for, we were following these truck drivers for a particular period of time. So you can see here the follow-up was in 3-month interval from 1993 to 1997. So the result was that 43 men became infected with HIV for a 3% annual incidence of HIV, and the uncircumcised men were 4 times more likely to acquire HIV/AIDS than the circumcised men. So when you look at this, just try to figure it out. Forget about a lot of wordings on the slide. We are just having truck drivers. We go here at our stage here at Makindu, for example, and then we enroll the truck drivers who want to participate. So out of them, we look at their characteristics. Maybe we see how many are circumcised, how many are not circumcised, and then we document. And then we follow them for even 5 or 6 years and see if what percentage will be HIV positive and what percentage will be HIV negative, and what is the percentage of those who are circumcised versus those ones who are not circumcised. So that is what we are talking, a cohort. The cohort here is the truck drivers who are being followed for a particular time. So cohort studies, the example that I have given is a classical example for a cohort study, where cohort studies is when you look at people over time. There is no control group. So you just look at them over time, either retrospectively or prospectively. Retrospectively is where you look at their history behind. Prospectively is where you follow them going forward. For example, you have seen in that study of truck drivers, we followed that cohort from 1993 to 1995 to determine what? The outcome. So this study was basically prospective study, where you start far to left on those so you follow them to the timeline going forward. So you identify your study subjects, you classify them based on the exposure status. That is, here we talked about circumcision. That is the exposure. So this was circumcision, or the circumcised versus the non-circumcised. So, and then you follow them over time and see which one gets a good outcome and which one gets a poor outcome of a disease or not a disease. So cohort studies are said to be more powerful study design because they measure of disease frequency, and we can be able to calculate the incidence rate, because we can be able to see how many developed the disease. So, and often that is really what we want. That is really what we want to do, to find out how often the people acquire this infection or this disease. So this is calculated as the number of new cases of disease over the total person time at risk, whereby you take the persons who have had the new cases over the person who are at risk times time. So the total amount of time that the people are followed is also put into consideration, and the measure of disease association is calculated from a cohort study. Because we can be able to say that we can be able to form an inference and say that those who are circumcised happened not to have developed diseases as compared to those who are uncircumcised. The advantage is that we can calculate incidence. That is the new cases. I will show you what we mean incidence in the later slides. So it is good for rare exposure, that it assesses multiple outcome, and then it establishes temporal sequence, because we can be able to say categorically that circumcision or circumcision is associated with reduced number of HIV incidences or the new cases. So disadvantage is that it is expensive in terms of money and time. Imagine you are following a person for 5-6 years. Yeah, so it is very expensive. And then you can also be able to lose some of the study participant because they can opt out. 5 years following a person things may change. So it's likely that most of them may drop out, and you can also have some bias. So if any question when you are talking about cohort studies, any clarification that you may want? Okay. So we continue, we complete that, and then we have a break. So the next one, I'm also going to give you a case. You know, these cases actually bring some of these things into reality. Yeah, you see how it has been applied. Because if I just come and tell you a cohort, an exposure and outcome, so you even wonder, what is that? What I'm talking about? Who is a cohort? But when now I tell you a cohort is that truck driver that you are following, it now makes it much easier for you to get it. So we also have another case here where we have male circumcision of HIV prevention in young men in Kisumu, Kenya. It was published by Bali and Lancet 2017. So the objective was to determine the association between male circumcision and HIV, and the study population was HIV negative males. We had those ones who were exposed, who had male circumcision, and the others who are unexposed, meaning they have delayed circumcision. So we have you go to just find a particular group of men, and then some you circumcise, some you don't circumcise, meaning that you are intervening. When you are circumcising them, it means you are applying what? An intervention. Remember, in a cohort, you don't do anything. You just follow. But here you can see you are doing something. So the outcome is that there is incidence of HIV type 1 infection after 24 months. You're supposed to see. So the result was that there were low risk of HIV among circumcised men than uncircumcised. So that one is an example of a study called a randomized control trial, and it's essentially the same thing as a cohort study. The difference here being that you are assigning exposure status. In a cohort, you find them naturally, so you follow them, you don't do anything. But here, in a randomized, you are assigning them an exposure status rather than simply observing and selecting people based on exposure that already happened. So you start with people, all of them have not been exposed, and then you randomly select which ones get the exposure and which one does not get. So it becomes a randomized controlled trial. So the advantage is that in this randomized control studies, it is a gold standard, meaning it gives you, it confirms to you, it is an experiment that you are doing. So whatever the outcome that you find, it is a confirmation. There is nothing like, about it, because it gives you the temporal sequence. It answers your scientific criteria. So randomization theoretically eliminates confounding. Confounding are those factors that affect a study, and then it allows causal inference. Causal inference is where you can be able to say a particular cause is leading to a particular outcome. So that is the causal inference. So disadvantage, it is expensive because you have to have those groups, you apply an intervention, so it becomes expensive, and then also you follow it over time. You can also lose follow-up and can bias study results, and it is not always ethical to randomize. For example, now circumcision, it is helping, but you choose not to circumcise others at the expense of a study. So sometimes it is not ethical. So those are the handicap when it comes to that. And then finally, we have another separate study called a meta-analysis. The last of our analytical study design is actually a hybrid between epidemiological study design and analytical method, and it is called a meta-analysis. And this is usually just a synthesis of existing literature. We ask you to do literature review. So in a particular topic, you look at all the studies that are available. Yeah. So you conduct an exhaustive search and actually identify every single study that has ever been published on that topic. So it is an extension of a systematic review, because you actually reanalyze the data, taking into account every single result and combining them, often in a summary statistic. When you look at this, when you look at this is what we are talking about. Look at all these studies, and then you put that statistic there. Yeah. So this is called a meta-analysis. You can see this was published in 2014, 2009, 2011 in a particular subject. And then you look at all their statistics, and then you calculate a particular mean. So they are summarized as you see on the plot on the slide with one line for each study, and its odd ratio are on the right side, and then the boxes represents the odds ratio, and the line and the confidence interval, and you can see this odds ratio that fall on the right of the solid line, they are positive association. So here, you calculate the odds ratio. You can look at this. So those ones on the right, these ones here, they are normally positive association. So you can be able to say a particular issue is associated, or a particular exposure is associated with a certain outcome. And those ones on the left, this odds ratio, they tell that there is a negative association. So, and you see that those odds ratio that fall on the right of the solid line are positive, and those that fall on the left are inverse association, meaning it is protective, or they are less likely to have the disease. So these studies are quite inexpensive. It only requires time to analyze and to look for those studies, but their validity really depends on the quantity and the quality of the studies that you have included. Because if those researchers before didn't do a good job then also you as now who is doing the meta-analysis, you are going to find that your study is equally not going to be true. And that marks the end of epidemiological study design. So in a nutshell, or in summary, we have been able to talk about epidemiological studies where we discussed descriptive and analytical studies. In descriptives, we have talked about case series, case report, and also ecological studies. And then in analytical studies, we have been able to talk about cohort, we have talked about case control, we have talked about randomized control studies, and then we have been able to talk about cross-sectional studies. Each and every of these studies have been able to look at the examples or the research studies that are existing or published, and then we went further and talked about the advantages and disadvantages of each and every study. So, is there any question or any clarification that you may want? Any clarification? Any question? Okay. So having been there, no question, we shall take 10 minutes break and we come and do our second session. Or how many minutes break do you want? We have to agree because we said we'll have a 2-hour session.
Tuendelee tu tumalize hiyo 2 hours.